Hello everyone. So far we've been building upon how to approach complex mitral valve disease, going from degenerative type 2 to restrictive type 3. In this episode, we're going to approach something that's vexing for cardiologists and surgeons alike, is the management of mitral annular calcification, or MAC. Now, MAC is not the same for every patient. It can be focal, it can be diffuse, it can even be circumferential. We have many different tools to deal with this, including transcatheter therapies, and when we approach this surgically, it can either be repair or replacement, depending on how MAC integrates with the leaflet tissues themselves. But in the setting of MAC, that can be focal or diffuse posteriorly, or also including the entire circumference of the annulus. Different techniques are needed to approach this challenging problem. We're going to show you a case of repair and a unique way of resecting the MAC and doing a mitral valve replacement. Let's have a look.
Now, building upon all that we have gone through, how do we manage patients with severe MAC? So this is a healthy 60-year-old patient with atrial fibrillation, mitral regurgitation, and severe MAC. As you can see by the TEE, the regurgitation is largely propagated by significant MAC at the level of P1, but also P2. This is what it looks like. The patient had atrial fibrillation, so we're going to proceed first with a full Cox-Maze procedure robotically, as we have demonstrated previously with the epicardial coronary sinus lesion, the inferior box lesion into the left atrial appendage, and the superior box lesion, followed by the mitral line, and the completion of the right-sided lesions with the vertical atriotomy of the right side, completion tricuspid line, the SVC line, the right atrial appendage line parallel to avoid the mid-right atrial body, a nice demonstration in this case, and the IVC line. And then we'll proceed to close the left atrial appendage in 2 layers through obliteration, as we've demonstrated previously. So now have a look at this valve. So the valve has some myxomatous change, but the mechanism is predominantly MAC. And it's due to this large spicule. It's almost like a diving board that's propping up the mitral valve. First step is to remove any damaged leaflet tissue, as was noted there, and begin to debride this large spicule. We have a suction aspirator that can help suck up any debris. And now we can use ultrasonic aspiration, but this goal on this particular case was largely to debulk, because we have some reasonable leaflet tissue. As you can see, there's significant ventricular penetration of this MAC, and a significant debridement done here may be problematic in terms of the concerns of AV dissociation or other issues, largely because it's deeply ventricular. So I'm proceeding to do some release of the anterior leaflet. You can see this large defect now, but the leaflet seems to be reasonable, fairly good motion. So instead of proceeding to do complete ventricular resection, which is feasible, it's of somewhat increased risk done robotically, but not impossible. Other colleagues have done this with electrocautery, but because this was fairly deep into the ventricle, I elected to mobilize the leaflet and cover that through a mini slide of the P2 leaflet onto P1, and then closing the cleft that was left and part of the commissure to help bring this together, thereby essentially covering that MAC area, yet allowing leaflet motion. This is the most important. Your goal here is to release restriction, not propagate it. So by so doing, we've now released all of the tension and tethered cords to the MAC bar. And while a little unconventional, we do have relatively decent motion, even of that prolapsed area. So now we'll address that area. You can see relatively normal leaflet motion of the anterior and P2 to P3. And since P2 to P3 is relatively intact, we'll do final little minor releases at the base of P2 here, and then close this cleft. In a relatively standard fashion with interrupted suture. Now, once that's done, we'll do a final test. And while the ratio of the anterior and posterior leaflet, there's still a fair amount of posterior leaflet height, the anterior leaflet is not overly robust. So decided to put a large, flexible 42 millimeter band, creating a nice orifice with excellent competence. And you can see the left atrial appendage is obliterated, and there is no residual leak with a mean gradient of 2. And this patient went on to do very well. What happens when we have really severe MAC? And this is a patient that was referred for transcatheter mitral valve replacement, but the patient's calcium was too high a burden, was turned down for TMVR, had severe COPD, and was an octogenarian. So tolerating a sternotomy would be unwise. So we elected to perform this robotically, and this is a full MAC resection. In this case, we have a planned replacement in this 80-year-old patient. You can see the significant debridement facilitated by the suction aspiration. And in this case, I did elect to use the ultrasonic aspirator. In the United States, it's known as the Sonopet device, to help facilitate further debulking. The Sonopet device works well, but is not a panacea. And then we use the anterior leaflet as a patch to patch that defect after debridement. We've been doing this for over a decade, and doing this robotically and working extremely well. So now we've covered the posterior MAC and the posterior annulus, and then proceed to put a replacement of a bioprosthesis, given the patient's age, in the techniques we've already previously demonstrated, which worked extremely well for this complex patient with a good result. So these are some steps to avoid and manage MAC.
So now we've seen how to manage mitral annular calcification. Again, like we talked about earlier, this can be multifaceted, but this gives at least some basic principles of how to navigate these complex patients. Join us for our next episode, where we're going to talk about how we can approach mitral valve disease when transcatheter edge-to-edge therapy devices fail.